Good morning everyone. Today we will discuss about NRP. As we know, NRP is neonatal resuscitation program. So what is neonatal resuscitation? It's a set of interventions which are used to assist newborn babies who have difficulty with making the physiological transition between the womb and the outside world. Before birth, the baby is in the mother's womb. So the baby is getting everything from the mother. Totally the baby is dependent there. The baby is getting the nutrients, oxygen, blood supply, everything from the mother. Once the baby is delivered, the baby is independent because too many physiological changes will happen to the baby. When the baby will cry, the lungs will inflate and the fetal circulation will turns to normal systemic circulation. So some babies have difficulty in making the physiological transition. These kinds of babies we will resuscitate. Okay, and if the baby, some babies are failed to initiate regular breathing, and we will tell if the baby is non-vigorous, also the baby need resuscitation. So tell me, what is vigorous and non-vigorous? Okay, if you want to tell the baby is vigorous, the three thing is very important. The main thing, the baby should have good respiratory effort, the baby should have good muscle tone, and the heart rate should be more than 100. If three things is present for the baby, we will tell the baby is vigorous. If the baby is good, if the baby have good crying after the delivery, maybe the baby have good respiratory effort, good muscle tone, and the heart rate is above 100. So simply some doctors they are telling, if the baby is vigorous means the baby is crying. Okay, so clear with the introduction. Then we will move on to the assessment of perinatal risk. In the assessment, we will ask 4 questions. First one, the gestational age of the baby, amniotic fluid is clear, number of babies, and additional risk factors. Gestational age we are asking because we should know the baby is term or preterm. So according to that, we should prepare everything. So then amniotic fluid, because if meconium, the previous NRP, the 6th edition says, if meconium stained, we should intubate the baby directly and we will do ETG suction. The latest studies and latest NRP says if the baby is flat or non-vigorous, no problem, we can go for the initial steps. Then we will re-evaluate the baby and if needed we will give PPV and we will assess for the number of babies also. So if twins or triplet or single baby, so if twins or triples we need additional personnel for help. So the 4th question we will ask is additional risk factors. We will ask for the placenta previa or placenta abruptia. So if there is such a kind of risk factors, we will prepare the baby for blood transfusion, O negative blood and volume expander. So we should ask. And always remember one thing, every birth, the one who can perform the initial steps of NRP and PPV should be present at every delivery before the birth. Okay, clear with the assessment? So now we finish with the assessment, then we will prepare the articles what we needed for the delivery. Okay, we will put pre-warm warmer, if preterm baby pre-warm incubator we will prepare. Then for the oxygenation, for the suctioning, for the intubation, for the medication, everything, the things we needed for the delivery, the whole delivery process we will prepare. Okay, then next thing we will move on to the delayed cord clamping. Delayed cord clamping should be done for 30 to 60 seconds. Okay, and especially remember one thing in delayed cord clamping, even term or preterm it's okay, but the baby who does not require resuscitation, we can delay the cord clamping. If the babies require resuscitation, don't delay cord clamping. Okay, and the main uses of this delayed cord clamping is the baby will go for less IVH. The baby have less chance of getting IVH, less chance of getting NIC, and less chance of getting the blood transfusion. Okay, nowadays we are doing the milking technique. Milking, instead of delaying cord clamping, we are doing milking for 2 times. Milking means just using the cord. Okay, now we move on to the algorithm. So now the baby is born. After the baby's birth, we will ask 3 questions: term, good tone, breathing or crying. If all these 3 questions is yes, we will give the baby to the mother for routine care. If no, the baby is term but not crying, not breathing, and not good tone, the baby is flaccid. So we will go for the initial steps. How many initial steps we have? We have total of 5 initial steps. Warm, position, suction if needed, dry, stimulate. So we will put the baby, after the delivery, we will put the baby on the pre-warmed warmer, then suction, then position, sniffing position, and suction if needed. Dry the baby, remove the wet linen, and stimulate by rubbing the back or flicking the soles. Okay. After the initial steps, we will assess for 2 things: breathing and the heart rate. Okay, now the baby is breathing, but the breathing is labored. What we will do? We will position the baby again, clear airway if there is secretion, connect the SpO2 monitor, provide supplemental oxygen, and consider CPAP. The main thing important is if there is labored breathing, put the baby on CPAP and shift the baby for post-resuscitation care. Now the baby is not breathing. Okay, not breathing, and the heart rate is less than 100, so we will move on to the PPV. So this initial steps and evaluating the baby and initiation of PPV, should all these 3 things should happen within 1 minute, that is 60 seconds. It's a golden minute. If any delay will happen in this 1 minute, it will affect the baby. Okay, so we will move on to the PPV. Once you will start PPV, you will connect the SpO2 monitor and ECG monitor, because in the delivery room, the only reliable method of assessing the heart rate is ECG monitor. Okay, so PPV now. PPV is nothing but positive pressure ventilation. So how many breaths per minute you will give for the baby? 40 to 60 breaths per minute. Okay, how you will do? We will do breathe 2, 3. When you tell breathe, you squeeze the amber back. When you tell 2, 3, how to release. So the lung will expand. Okay. So we will give this PPV for initially for 15 seconds, and we will assess for the chest rise and the heart rate. Okay. Now there is no chest rise. So we will go for Mr. Sofa. Mr. Sofa means MRSOPA. M for mask adjustment, R for reposition the baby, S for suction, O for open the mouth, P for increase pressure, A for alternative airway. So first we will do the 2 things, mask adjustment and reposition the baby. So we did mask adjustment and reposition the baby. Then we will give 5 breaths. Breathe 2, 3, breathe 2, 3, like this. We will give 5 breaths to the baby. During this 5 breaths, we will assess the chest rise again. Still there is no chest rise, so we will go for SO, suction the baby and open the mouth. So suction, always remember one thing for the newborn, suction from the first mouth, then nose. Yeah, remember always M after N. So mouth first, then nose, because if you do suction the mouth, the secretion in the, if you do suction in the nose first, the secretion in the mouth will get aspirated. So mouth first, then nose. The suction, then open the mouth. After SO, we will give again 5 breaths. 5 breaths. We will assess the chest rise again. No chest rise now. So we will increase the pressure. He missed so far. The next one is P. So we will increase the pressure. So the minimum starting pressure is 20, and the maximum for the preterm baby is 30, and for the term baby is 40. The maximum is 40. It should not exceed 40. If you exceed 40, it will affect the baby. So the baby will get pneumothorax. So the maximum pressure of the baby is 40. Okay, so we increase the pressure already. So now there is good chest rise. So it's okay, we can give PPV for 30 seconds for the baby, and we will evaluate the heart rate and chest rise again. Okay, if still after the 30 seconds of increased pressure still no, the heart rate is not increasing, we will go for the alternative airway. Alternative airway, we have LMA and intubation. LMA, there is some indications for LMA. If there is difficult intubation, we will go with the LME. Then it should be according to our NRP says. Once you want to give LMA for the baby should be more than 34 weeks, and the baby should be more than 2 kg. Okay, so now we will intubate the baby. So we intubated the baby. We will select the appropriate size according to the weight of the baby. According to the weight of the baby, we will select the appropriate size of the ET. Okay, and measure the ET tube length from the earlobe to the nasal septum. So now we intubated the baby. So we need to check the placement of the ETT first by CO2 detector, and check the bilateral air entry and the condensation of the mist should be present. Okay, so now the placement is okay. Then we will give PPV for 30 seconds. Then we will assess for the heart rate again. Now the heart rate is less than 60. So we will consider chest compression. Okay, once you start chest compression, you will put the FAO to 100%, connect the ECG monitor if not connected before, and consider UVC. Okay, chest compression, we have two techniques: two thumb encircling technique or two finger technique. Okay, just below the nipple line, 1/3 of the anteroposterior diameter, we will do the chest compression by like this: 1 and 2 and 3 breath, 1 and 2 and 3 breath. So if you count 1 and 2 and 3, you will do the chest compression. When you tell breathe, we will squeeze the amber back. Okay, so 3:1. It means in 1 minute the baby will get 90 chest compression and 30 breaths, totally 120 events in 1 minute. Okay, while once you start a chest compression, don't interrupt in for 1 minute. So you will continue chest compression coordinated with the ventilation for 1 minute. After 1 minute, again you will assess for the heart rate. The heart rate is still low, less than 60. So we will insert UVC and we will consider epinephrine. Epinephrine we will use for the IV 1:10,000. From this 1:10,000, the dose is 0.1 to 0.3 ml per kg. First dose will be 0.1 ml per kg. Every 3 minutes we will give the dose. Second dose will be 0.2 ml per kg. Third dose will be 0.3. The maximum is 0.3 ml per kg. If there is no IV access, it may be very difficult insertion of UVC. So you will give adrenaline via ETT 0.5 to 1 ml per kg. Okay, still after everything, we did everything. We intubated the baby, we given chest compression, everything, but we given epinephrine. Still the baby is not improving the heart rate and the saturation. Consider hypovolemia, consider pneumothorax. If there is hypovolemia, treat with normal saline 10 ml per kg and consider pneumothorax. Okay, this all about our This is all about our NRP, and we have the targeted preductal saturation after birth. Always remember one thing: when the baby will go for 10 minutes, the baby will reach the full saturation 85 to 95 percentage. Okay, and the thermoregulation is very important for the baby because it's a quality indicator. If the baby's initial temperature is very low, the prognosis will be very poor also. Okay, and for the term babies, when we are starting resuscitation, start with room air, that is 21 percentage of oxygen. For the preterm babies, start with 21 to 30 percentage of oxygen. Okay, and we have the after even term or preterm babies, after resuscitation the baby will go for hypoglycemia, so you should monitor the blood sugar level, and if there is hypoglycemia, give DTN water 2 ml per kg. Okay, and according to our ethics, according to the NRP, if the baby is less than 25 weeks and with severe congenital malformation, do not resuscitate the baby. Okay, so I think I finished with the NRP. I hope everyone understood. Thank you.